Good morning, everybody, and welcome. My name is Linda Benton, and I'm here on behalf of Johnson & Johnson, who's the sponsor of this session in this absolutely beautiful place. I've been here the last couple of days. I was here last year, and every time I come here, I'm amazed at the beauty of this area. So I hope you enjoyed this session. As a little bit of background, in case you're wondering why Johnson & Johnson is here and sponsoring this session, we have been proudly championing and supporting the nursing profession for over 125 years because we know that nurses are the very backbone and the heart and indeed the engine that keeps our healthcare systems running. Healthcare is not going to work without the nursing workforce and others on the front lines of care. And that is precisely why we're here today this morning. Our healthcare workforce, inclusive nurses and all on the front lines of care, are now facing a new epidemic. And unfortunately, it's called moral distress. You may have seen an article on it in the New York Times in the last couple of weeks, and there's actually an article on LinkedIn this morning as well coming from Beth Kutcher. So it's front and center for sure. And certainly, it's non-negotiable. We know in terms of where we are today with all that our frontline healthcare workforce has been through, it is absolutely time for change. It is not an option. We must do better to care for the people that are delivering healthcare for us each and every day. And fortunately, there is a really positive pathway forward that you're going to hear about this morning from our panel. So very pleased now to introduce our panel moderator, Shauna Butler, who is a passionate, innovative nurse economist and host of our own See You Now podcast. Shauna?
Thank you. And first, thank you. I will take all the applause I can get. Thank you for being here with us. And I know why you're all here, because everybody needs and is looking for nurses, and you have come to the right place. As Linda said, the headlines across the country, but actually across the globe, share really alarming stories and details about nurse vacancies, nurse departures, their distress, their concern for patient safety, and just how hard it makes it for all of us to try to deliver the care, the broad spectrum of care that all of our communities need and deserve. And actually, our healthcare workplaces and work practices are exhausting and many times demoralizing. And I think we've seen those stories. And this emotional and physical toll that it's taken really does explain why you're seeing a lot of very talented, very skilled, very dedicated healthcare professionals deciding to depart. And what this does is that it leaves a crisis in caring. And when we have a crisis in caring, when it's left unaddressed, what that means is it's harder for people to get care. Healthcare costs more. Healthcare, our disparities in our health widen and worsen. And actually, care just feels less caring. I am Shauna Butler. I am a nurse, and I am obsessed with the economics, the policies, and the technology of health, how it gets delivered. The podcast See You Now, we explore all of these societal challenges, how they show up in healthcare's door, and very specifically how nurses are leading and addressing them. And I have colleagues who are equally obsessed, and they are also very concerned about the well-being, the safety, the readiness, and the preparation that our healthcare workforce is experiencing. We're actually here today to share with you and amplify the U.S. Surgeon General's recent advisory on looking at the extreme moral distress that our healthcare workforce is experiencing, but more importantly, the actions that are necessary and readily available for us to take so that we can think about, but at the system level, how we're going to actually improve the lives and the practice of our healthcare providers that then you all get to benefit from. I'm really curious how many of you have actually experienced a delay in care or seen care that was felt really rushed and maybe you didn't feel like it was the care you wanted. Yeah. I see a lot of head nodding. I'm sorry about that. We are doing our best. But today, joining me, I have colleagues who are going to share some of their wisdom and their experience. So Iman Abuzaid, she is the co-founder and the CEO of Incredible Health. So it's this data-driven platform that is actually helping nurses find and do their very best work, live their best lives, and employers their ability to hire in less than 20 days versus the 90-day average of permanent employment. And Kathy Howell, she is the Chief Nursing Executive at UC Health, UC Colorado Health Systems, here in Colorado. I'm sure that many of you have gotten your care from many of her team. So it's a large nonprofit health system with a workforce of 28,000 employees. And Corey Feist, who is a very seasoned healthcare executive and recently the CEO of the University of Virginia Physicians Group. So that's about 1,200 plus physicians at University of Virginia. But more recently, the co-founder and the CEO of the Dr. Lorna Breen Heroes Foundation. And I'm also very pleased to say that the co-founder of that, Jennifer Breen-Feist, is here with us in the audience today. So I want to thank her for being here. And what I want to start out with in each of this is a little bit of context setting and attention-grabbing stats. So, Corey, each one of them is working on some portion of the distress in the healthcare workforce problem. So I'd love for you to share, set some context and provide some alarming statistics about what you're, scare the room.
I'm gonna stand because I'm going to run out the back.
who you're talking to, and what you're hearing from them.
Thanks so much. I'm going to use some notes because the data is pretty astounding. Thank you, Shauna. Thanks for everyone being here. The Dr. Lorna Breen Heroes Foundation was created by my wife Jennifer and I in 2020. And our entire team is laser focused on this issue. We are laser focused on supporting the mental health and well-being of our healthcare workforce. I'm going to go through some stats, but you're probably not going to be able to remember or recite all of them at the end. But I want you to walk away, at least hopefully, feeling prepared to have a conversation about this, feeling inspired that there's work to be done, but more importantly, feeling committed to join us all in this arena that we've decided to dedicate our lives to. As Shauna said, I've been working my entire career in healthcare. First, as an attorney. I was on the good side, if there's such a thing. But then I found religion, got an MBA, and became a CEO. I'm still working through the ethics process. It's tough. But I was in healthcare my whole career, which is why, following a family tragedy, that the outcry from the healthcare workforce to our family tragedy by thousands of healthcare workers that Jennifer and I didn't know before they responded to us was why she and I, and now our broader foundation, have stepped into this arena and stayed in this arena. For those of you who may know or may be familiar with Lorna's story, she was an emergency medicine physician at the peak of the pandemic in New York City. She worked at Columbia Presbyterian Hospital. And over the span of just 3 weeks, just a 3-week period of time, treated confirmed COVID patients, contracted the virus herself, and then returned to an overwhelming, relentless number of incredibly sick and dying patients, which caused for her first and only mental health issue of her whole life. We like to say that Lorna answered the call for her city and her country, and obviously her patients. But when she needed to make a call to take care of her own mental health and well-being, she was so fearful of the professional repercussions that she died by suicide on April 26, 2020. Only 12 hours after that, the New York Times decided it was in their best interest, over the family's objection, to publish her cause of death. So we're here today. But after that publicity, we heard every day for years now from healthcare workers about the conditions in healthcare. And the consistent refrain was, enough is enough. The working conditions, the culture, the high incidence of suicide. I don't know how many of you knew this before the conversation. And the mental health obstacles were all challenges that Lorna faced. And we could not simply ignore them as a foundation. So among the issues that the workforce raised to our attention were the fact that nurses and physicians in this country die by suicide at twice the rate of the general population. I have a physician statistic on this in terms of a total number, not a nursing statistic, but that means 400 doctors a year pre-pandemic were dying by suicide in this country. That was before we asked healthcare workers to put aside their own safety, take care of our friends, our family members, put themselves in harm's way. And like Lorna, many nurses and many physicians and other healthcare workers suffer in silence due to these cultural obstacles. So let's talk at some of these numbers for just a second. Pre-pandemic, 96% of medical professionals pre-pandemic agreed that burnout was an issue. 35 to 54% of nurses and physicians and 45 to 60% of medical students and residents were already reporting symptoms of burnout before the pandemic. 42% of physicians were reluctant to get any kind of treatment. 69% of nurses say they put the patient health and safety before their own. And only 31% felt like their employers cared about their mental health. Throughout the past 36 months, our foundation has been working with all healthcare professionals, trying to scale solutions at the policy level and at the practical level. And one of the most exciting things we got to do was, in an 18-month period of time, pass the first ever federal legislation looking out for the well-being of the healthcare workforce, named after Jen's sister, Lorna, the Dr. Lorna Breen Healthcare Provider Protection Act, signed by President Biden last March. And shortly thereafter, we launched this All-in Wellbeing First national movement. Note, we call it Wellbeing First, because that's what needs to happen here. We did that with our partners at Harvard, at Thrive Global, at the Creative Artists Agency, and organizations that represent over 1 million healthcare workers. As part of that, we created a Caring for Caregivers program, which has all these data-driven steps. And here's some more data for you, so get ready. One of my favorite parts of the data-driven steps is to eliminate the stupid stuff, we call it. Well, when you think that half of a nurse's time, 50% of a nurse's time, and 70% of a doctor's time in this country is spent doing administrative work, not taking care of patients, I consistently argue that we don't have a workforce shortage in healthcare. We have the workforce doing the wrong thing in healthcare right now.
Yeah.
Thank you. So let me share with you very briefly what happened after the law passed, and then I'll wrap up with the stats. The Surgeon General, in May of 2020, issued his advisory on healthcare worker burnout. The National Academy of Medicine, a couple months later, published their national plan for healthcare worker well-being. Then in October, the American Hospital Association published its first ever suicide prevention guide. So now, where are we? Where are we in this conversation? Now we have 64% of nurses stressed, 57% exhausted, 43% burnt out. 53% of doctors are burnt out. 23% of them, by the way, are experiencing depression, which is 4 times the average adult population experiencing depression. 60% of healthcare workers say stress from the pandemic has harmed their mental health. And here's the most tragic piece. Less than 50% of healthcare workers, regardless of role, feel valued and supported by the organizations that they work in. So, I want to just wrap up with the number one driver of all of this. Pre-pandemic, during the pandemic, and post-pandemic. Spoiler alert, it wasn't the pandemic. It was the administrative burden that healthcare workers carry every day. That continues to be the number one driver. While there are a myriad of factors, we are laser focused right now on these big boulders. I know we're not in Boulder, we're in Aspen, but they're rocks. Okay, fine. I tried an Aspen thing, but it didn't work out. A grove of aspens, sorry, there you go. Anyway, as we think of where we go, as Linda just asked you to raise your hands and think about, like, where have you experienced this? This is an increase in medical errors, a decrease in ability to get to a doctor or a nurse, be treated. These are all experiences that we're having. And as we kind of move into the rest of the panel, I just want to invite you all to join us in this arena. We've all decided to lock arms on this issue because it actually impacts every single person in this room, directly or indirectly. So thanks for letting me work from a piece of paper for this part of it. But that's the work, and I look forward to the rest of the conversation.
Well, thank you. And I want you to know that I feel Lorna's spirit very strongly here today, and I'm very grateful for the fact that you have taken this on. Iman, is it 1 in 4 nurses in this country who are on your platform?
Correct, yeah.
And how many health systems are you chatting with?
So we work with over 700 hospitals across the country, including large ones like HCA and Tenet, academic medical centers like Johns Hopkins and Stanford, lots of community systems as well, right? Yeah.
Okay, so what are you hearing as far as the message that they're sharing with you, and what is it that's working? You know, I think we are hearing what the pain is. We know what that is. Yeah. What are the requests, and what are the things, maybe as far as mindset, that are getting in the way of doing some of these things that Corey and the foundation are working on?
Yeah, so what we're hearing from the nurses, because when they're signing up and creating a profile on our platform, we're asking, why is it that you're considering leaving your job? Number one is they're looking for more career advancement opportunities. They want training programs, the ability to cross-train to another specialty, the ability to move into management, the ability to get specialized faster. So this is definitely a workforce that is looking to advance their career. The second thing that we are hearing more and more, and it's showing up in our data, is a desire for more flexible scheduling. 80% of nurses want more flexible schedules. They're busy people. They've got kids, they're caring for older family members as well, and they want to be able to fit work into their life. But even though 80% of nurses want more flexible schedules, only 11% of hospitals offer flexible schedules. Another area is the desire to pursue opportunities all over the country, to relocate, even to reduce their commute time, even in their current city. And when you apply just the more traditional way to other hospitals and health systems, you usually don't even hear back. Right? You apply to 10, 15 places, you usually do not hear back. And so there's something very broken
there. And there is, by the way,
right?
there are high vacancy rates. You hear this word shortage. Say that again, like people don't respond. You've got nurses who are applying for open positions, and they don't hear back.
They don't hear back.
They don't hear back.
And then finally, just, of course, this is table stakes, but compensation, benefits, desire for more of that. Now, look, I do empathize with the other side, right? I empathize with the hospital leaders.
You're sitting next to one.
I'm sitting next to one too, I mean, they have a tough job, right? They are running businesses that are very low margin, and less than 2% margins usually. And these temporary labor costs, because many institutions have had to use temporary labor to fill in the gaps, are costs 3-4 times more than their permanent labor, and that eats into their bottom line. And so they are under pressure to solve these challenges. And then solving these challenges, though, is not that easy, especially when you have a workforce of 28,000, is that right? And they are dealing with 5 generations in the nursing workforce, right? From the baby boomers all the way down to Gen Z. And guess what? Each generation wants something different, right? And our data shows that younger nurses, the Gen Z and millennial nurses, they actually have more of a desire for the flexible schedules. They want to get specialized immediately, right after nursing school. They want to start specializing. The desire to get compensation raises is much more than older nurses. And so they have tough jobs. They're tackling all of this. But I am very hopeful about the time we're in now, because there's been an enormous amount of media attention on this problem and on this workforce. The hospital leaders are more focused on this challenge, and we're at a point where the CEOs, the COOs are diving into this problem too. It's not just the nursing leaders and HR leaders. And so I am hopeful about the changes that are to come.
All right, Kathy, so you're one of these people that Iman is talking about.
Yes, I am.
So you're on a daily basis, you are immersed in the weight that so many of our healthcare professionals are carrying. You're seeing what is eating at their souls oftentimes. And this flexible scheduling piece, I mean, all the different types of solutions that you have available, you have been bringing in some really dramatically different approaches to how careers can be developed. Why don't you say more about what you're hearing, and more importantly, what are the things that you are working on that you're seeing actually make a difference?
Yeah, what you've all heard, what we can't do is continue to circle the drain. And kind of our narrative is we cannot utilize a pre-pandemic approach to how we're dealing. And the whole care environment needs to be transformed. Because what you hear in the media and everywhere, and even lots of our own executives hear this, is we just need to educate more nurses. There's 4.2 million nurses, 85% are working. If the population keeps aging, we're going to need 500,000 more. You see all those stats. But we can't just keep that, because that's the hamster wheel. What we've got to do is transform our care environments. The other piece, the 2 things that really, when I think of my team, and we have over 9,300 nurses, is number 1, nurses have had a contract for decades and years with civil society. And that is, we'll care for you no matter what. You enter our doors, we ask no questions. We don't care where you come from, what you have, what your beliefs are. We care for you. And that's our oath we take. But that civil contract has been fractured. It was happening before the pandemic. The pandemic just amplified it. And this is a big issue with nurses. And it is being safe at work. 1 in 4 nurses have been assaulted in their career. Over 75% of the assaults that happen in work environments happen in healthcare. And there's so much incivility. Actually, I've been spending probably the most part of the last 2 years working on workplace violence prevention, educating our nurses and training our nurses to understand how to really even be physical and how to take somebody down, because your life is at stake. I mean, 10 years ago in healthcare, when we were training on basic de-escalation, it was like, no, that's security's job. Well, it's your life at hand. I mean, nurses get choked, they get punched, they've been sexually assaulted. I can just tell you, and I get an email every morning, early morning, myself and our chief human resource officer across all those nurses and the other care team, and we get to read every day what happened. And then so much of that is underreported. So one big thing, and again, it's for us in civil society, is to say enough is enough. Like, this is a place, this is a sanctuary where you're getting care, and please be kind, and we'll be kind back to you. And then the other piece that's really eating on nurses is they're still recovering from moral injury. And there's a lot out there, and I'm lucky to work for a health system that we have a chief wellness officer who is a physician. It is her academic interest. I work with Liz all the time and the nurses, and we put in a lot to support our teams. And I tell you what, we put in a call line in, I think it was 2020, 24/7. It is a licensed therapist on that line, 3 in the morning. I don't care. We don't ask questions. You got an issue, you call them. And I tell you what, I think that has been a lifesaver for all of my nurses. And we're having conversations that we didn't have pre-pandemic about, how you deal with your mental health. And it's starting to become more of our normal conversation, which is really healthy. And then also, we are each other's keeper. It's like, if you see me getting, I'm going down the drain, please help out. And there's a number to call, because pre-pandemic, we didn't have this. It was like, we had an EAP, we had lots of doctors around, a psychiatrist to call, but it was like there was nothing instantaneously that you could call to get somebody immediate support. So those are kind of the big issues out there that I'm dealing with our teams. And as you say, I see a lot of healing happening, but when you think about this globally across the country, we need every single health system to really be focused on this. And the board of directors is a great place to start. If any of you are on boards, board of directors, demand it. Ask about what you're doing for the mental health of your teams, because that will help drive differences.
So Iman, you had mentioned that one of the 4 major requests that all nurses have, flexible scheduling. So first of all, I'm not sure how many people know what scheduling looks like when we're talking about this. Kathy, you're in the best position to speak to. What does scheduling look like? And more importantly, how you guys are doing some really fun, interesting, exciting things they're dramatically shifting how people experience their careers. And one of the things, too, that I've had many nurses share with me is that, and particularly our younger nurses have said, I hear your generation. I don't want to go for this work-life balance. I am looking for life-work boundaries. Mm-hmm. And kudos to them for teaching me that. And so I'm passing that all along to you. But why don't you speak to what these schedules look like and what you guys are doing?
Yeah, a typical schedule, I'll just talk about a hospital nurse, is 3 12-hour shifts a week. Have some time off. They work every third weekend.
Wait a minute, 3 12-hour shifts does not equal time off, but go ahead.
Yeah, right. That's the normal schedule. What we did is last year we sent out a survey, because we are modernizing our benefits globally for all 28,000. And of course, flexibility came up to be number 1 for everyone. So we wanted to do a deep dive into our nursing team. So we sent to all of our direct care nurses, 7,200 of them, to say, what does that really mean? You've got this, you've got this, you've got this. And really what came back to us is, I want to have more extended time off. I want to take off when I need to take off. And so we actually we just launched in the middle of May a program where nurses can work 3 months and take a month off. Work 3 months, take a month off. We'll see how that goes. We also put into place what I call Match.com for nurses. It's called RN Match. And so I'm a nurse. I've been working neurology for 4 years, and it's like, gosh, I really would like to try emergency medicine, but I don't know if I really want to leave totally. How can I do both? So we have a matching program, competency-based, so that they can do part of their hours in neurology and the other ones in emergency medicine. And that's been real satisfying. But I have to tell you, you have to have lots of these. That's not enough. We have a lot of fellowships and career mobility programs. I've tasked my team this year is like, I need an app. So if there's any producers out there or app builders out there, we need an app, a mobility app that we can put in all of our programs online. I say, you know how it is when you're planning your financial life? It's like, if I save $25 for 100 years, I can retire. We need those apps that our teams have to know what's available to do, because there's lots of opportunities for mobility. But I know them and my leaders know them, but does every frontline nurse know them? So that's our next big thing, is like, we need to develop this app and include everything there, and then have career coaches that can really get on the app with you to really help you curate your career.
So Corey, Iman, you both are talking to a lot of system leaders. I think Kathy's an outlier, am I right?
Yes.
Okay.
In a good way. Let's be clear.
In a good way. We want more of these outliers, just to make that clear.
Yes.
So I want you to speak to a couple of things. One is, what are the things that you're seeing that are actually working? Kathy's given us a couple of examples. But what is the mindset and the attitudes of those teams that allow them to let go of some old ideas that aren't serving us well? And maybe what are the things, why are they clinging so hard? Like, what do we need to help them with mindset? So first, what's working? And then what mindset needs to change? Iman, you want to start?
Sure. As far as what's working, and first of all, we have to determine let's define what's working. Essentially, the vacancy rate has to come down, the turnover rate has to come down, the employee experience.
When we say, give the numbers, like what the vacancy rates are.
Sure. I mean, the vacancy rates are
astronomical.
very high, right? So we're talking about anywhere from 4 to 10% vacancy rates in different parts of the country. As far as turnover goes, the national turnover for hospital nurses is at 25% right now.
So think about your workforce, like annual turnover. How many? Yeah.
So these are some very, very tough statistics to deal with, and that are directly impacting the bottom line of the hospital too. And so as far as measuring what works, you have to tie your solutions to one of these important metrics, which are effectively financial metrics. When you implement career mobility, like Kathy just described, what does that do to your retention? Likely improves it, right? When you hire more permanent nurses, how many travel nurses can you exit from your health system so you can save on those costs? So it's, regardless of the solution, there are many solutions out there. So for career advancement, there's the career mobility planning, the career tracks for nurses, the training programs for nurses. In the flexible scheduling place, essentially more and more leaders are offering a whole menu of options for schedules, right? Weekend shifts, 8-hour shifts, 4-hour shifts.
Virtual nursing.
Virtual, this
hybrid.
Many options. Of course, very tough to manage operationally, but it is what the talent wants. And so all of these solutions all need to be tied to a financial argument at the end of the day. And when we see nursing leaders and HR leaders partnering really well with the finance leaders and teams, that is actually when the magic actually happens. Because if you can propose programming and changes that are budget neutral, or let's say they do have costs associated with them, but the health system is going to save, in the millions of dollars on the back end, that is, of course, anyone's going to agree. These are no-brainers then, right? And at the end of the day, the hospital leaders are business leaders at the end of the day. And so all of these, different topics that we're referring to when we talk about the moral distress of the healthcare workforce does actually boil down to dollars and cents. And if you can speak that language, then you're going to implement a lot of solutions. The other thing that I've seen be very successful is when hospital leaders recognize that the game has changed. I mean, I think it was one of the first statements out of Kathy's mouth, right? That we cannot operate like we did pre-pandemic. The entire market has shifted. The labor shortage is even more severe now. The demands from the workforce has changed. The generations are changing. So when they recognize that, hey, everything happening outside of my health system has completely changed, and everything inside my system is starting to shift as well, I need to act, and I need to act fast. And when leaders do that, it's, again, the magic happens.
And Corey, I think one of the areas that I'd love for you to spend time on, because you're doing so much on the policy work, what are some of the policies, and when you talk about get rid of the stupid stuff, you guys, your foundation has been so focused on what are some of the major policies, because so much of this, I mean, you cannot recruit your way out of a retention problem. These are systemic level problems, and we need system level changes, and many of these are at the state and the federal policy level. So speak to that, like what you're hearing.
You can't yoga your way out of the problem either.
Yeah.
And so, in all seriousness, I mean, one of the things that we use as an analogy at our foundation, our chief medical officer talks about, you've got at least two things going on with healthcare workers right now. They need individual support and they need systems change. And the way she describes the individual support is applying pressure to a bleeding wound when a patient comes to the emergency room. Our medical directors and emergency room doctors, so that works for her. But a lot of the things even that were discussed are individual support, and that's what the workforce has really felt heavily over the pandemic. Peer support programs and other programs have really scaled, which is great, but they only apply pressure to this wound. What you have to get is underlying systems issues. Those can be, and a lot of them are policy driven. Some of them are operationally driven. We talked about getting rid of the stupid stuff. So the stupid stuff involves a lot of administrative burden that comes from external sources to healthcare. They can be driven by an electronic medical record that was designed to document for billing purposes, but is used for clinical workflows, so it's completely inefficient. Or it can be from insurance companies, as an example, who require an infinite number of prior authorizations which add no value except to the bottom line of the insurance company. No offense to those who are insurance company in this room, but it's one of the biggest drivers. So what we've done is we've looked at a federal and a state level, and we basically said, you don't necessarily need to add more money to this issue, though the Lorna Breen Act added $140 million of new programs, which are desperately needed. But what you can also do is look, and the Secretary of Health was here yesterday, and I was dying to ask him, what administrative burden that you all carry through HHS and CMS and others that you're requiring of your healthcare workforce doesn't add any value. Get rid of it. That can happen at a state level, that can happen at a federal level, and that's the kind of conversation we need to have. When I talk to policymakers at a state and federal level, often I'm just saying, even being aware of the additional burden you may be adding through different policy. Oh, it's just adding one more document that a physician or nurse has to fill out. Well, let's not do that. Let's redesign it so you don't have to do that. So that's a big part of it. The other thing that we stumbled on, and this is what is so tragic among many things about my sister-in-law's story, is that she was incredibly fearful of the regulatory repercussions of getting mental health treatment. So those are real, and even as the general counsel of the medical group at the University of Virginia, I wasn't even aware of them because this is an issue that no one talks about. But they appear at a state level in licensing applications that nurses and doctors have to fill out. They appear at a local hospital level. When you go to apply to work there, you fill out a credentialing application. And all these questions, healthcare workers are taught from a very early age. You either can't get mental health treatment. If you need it, pay for it in cash, drive to another town, lie about it. And so what we've done in our foundation is we've actually established a toolkit. Wait for it, is 3 steps. It's really basic. Audit your questions, change your questions, and tell people that you changed your questions. And so what we've been able to do is audit the country for nursing licensing and physician licensing on this particular issue, and we're just working the problem head to toe and literally changing the landscape. I don't know if I could add a quick story I got overnight. I got an email from a clinician in Oregon. Yesterday, or 2 days ago, we changed the licensing laws in Oregon. And the licensing board emailed all their licensees to say, guess what? We have eliminated these questions. Well, overnight, I got an email from a clinician in Oregon who said, thank you, thank you, thank you. I'm up for my renewal application, and I was terrified.
I want to contrast that, actually. Yesterday, I don't know how many of you got to hear Iman speaking yesterday with Andy Slavitt. And one of the questions that you got asked is, like, how are you taking care of you? And the first thing she said is, get a therapist. I don't know how many clinicians would be comfortable admitting that they're seeing a therapist. I think that they would be very fearful. I think that a lot of that has changed, and a lot of that has been awareness. But I thought it was so interesting, like a CEO is, that's the recommendation, and very comfortable publicly stating that. And I still think that there's a long way that we have to go for most of our clinicians to say, I'm receiving therapy or I'm on medication.
And Shauna, I would just punctuate that by saying this is an issue that is new to many, even if they sit on licensing boards or they sit on the policy groups looking at these questions. Like, oh, we haven't looked at these questions in decades. I'm like, well, that's the problem. They all violate the Americans with Disabilities Act.
Yeah.
Use our toolkit. It's free, and change your stuff. So it's usually it's usually met with open arms. But what we didn't realize, even as healthcare leaders, because I have multiple degrees, but not an RN or an MD. I never walked that line. I didn't know how early and often the message is given that there are some opaque consequences to you taking care of yourself, whether it be mental health treatment or just taking a break.
Yeah.
It's a sign of strength to be burned out in the past.
It is, and I think Lorna's story really epitomizes that, because it wasn't the licensing laws that were preventing her from seeking care. It was the social pressures that you don't want to let your colleagues down, you wouldn't want to let other people know, because then there's this question, can we trust you? So all of this needs to change, and so much of the work that you're doing. I want to go, all of you have mentioned statistics and metrics. So two things that I want you to address here. What are the really important metrics that we should be measuring and sharing broadly so that people know how to assess the health and the well-being of their workforce, therefore their health systems, and what's the lowest hanging fruit for these types of changes so that we can see rapid change in those metrics of the health of our workforce?
You know, maybe I'll
Yeah,
start
Kathy,
with
go
that. And of course, you look at your retention rates, because, you know, people, and you also look at, and what we look at is there's a concept called PRN. It's like a per diem. Like, people maybe were in a full-time position, they cut their hours significantly, and then they can work on their own terms. We saw a huge, during the pandemic, we watched that data, we saw it. It's like, wow, what's happening? I mean, nurses always kind of did this because of life things, but we've seen it significantly, and we watch that number all the time. It's not a usual number you would think about. And of course, then our turnover and our retention rate as well. But the thing that every single health system should be doing exactly right now is what we call remove the pebbles from your shoes. And we actually use that language, and my colleague, Dr. Harry, and myself, as I lead with nursing, is we have lots of listening sessions. And that's the one thing, you know, I've learned from many, many decades of not doing it right is listen, listen, listen to that front line, and then do something about it. So we do all these listening sessions continually, and then it's like, okay, we got to do something about that. I mean, as simple as, I laugh about this, my latest one were the pillow wars. Like, somebody decided, I didn't know that, last year, that all of our nurse managers would be purchasing all the pillows for their units and tracking them. Really ridiculous. I call it the pillow wars. They brought it up to me, I go, what? I said, this sounds like the pillow wars. And so we immediately said, that's not happening, take that off of them, my goodness. You know, put a par level in, whatever, and it's done. But that's a simple one, but there's other big ones that really take care transformation. And I'm lucky to work with a very innovative CIO, and we have an innovation center. And what we do is take interested clinicians and say, come play with us. And I'll use my one of our last examples we did is around wound care nurses. Wound care nurses are very in short supply. They're highly educated and very specific about what they do. So you never have enough of them. So we said, come play with us virtually, and let's figure out how we can make your days better so you can see all these patients, because they had a backlog of patients that they couldn't see patients for 3 days. And I mean, it's a huge care and access issue. So they came and played with us for about 6 months in our virtual health center. They were able to develop some real specific algorithms based on data through the EMR, and were able to see 40% more patients because they have one of the nurses that's virtual every day doing all prevention rounds, and then the other nurses that are on the units can really take care of those patients that really need lots of hands-on care. So they increased their productivity by 40%. Well, of course, that's great for a CFO to hear. But you know what was more important? That's not what we were going after. It's like, how do we make your work life better? We were able to hire some technicians to help them, and they wanted them. And now they say we would never work in a different model again. But they designed it, we did not. Now, we didn't make a big deal about it at first, because you take a clinician off the floor and it's like, oh my God, You know, the CEO knows I'm doing this, the CFO, the CNO, it's just like, there's too much stress on them. So we say, just go play for a while, don't tell us what you're doing, and come back with some ideas so that they can fail and be okay. Because that's the other big pressure is how do you fail? But we have to have our clinicians designing our care models of the future, and we've got to have avenues for them to do that.
We're going to go to audience questions in just a second, and be ready. I want to, one of the things that you have, Iman, have really turned me on to, and I've become a disciple and an evangelist about, is removing friction. Because so much of the thing that we talk about is innovating like on the care delivery side, but not really on the back end, on the operational side. I mean, I've really caught the religion about that. So why don't you say just a little bit more, and then we'll go to question.
Yeah, absolutely. Look, there's a lot of innovation in healthcare, especially innovation that's patient-facing. But the truth is the major costs in healthcare are in the back end of healthcare. The hiring, the way the operations of the health systems, just the boring stuff, basically, right?
The very unsexy stuff.
Very unsexy stuff,
Yeah.
But that is like, the majority of healthcare costs are tied up in that. We really focus on the hiring piece. So I guess the interesting statistics I wanted to share was, we operate in many across 27 states and many of the major metropolitan markets. When we started our company 5 years ago, we thought, hey, it's going to be the hospitals that pay the most and the ones with the biggest brands that are going to hire the most from our marketplace. And it turns out that's categorically false in every single market where we operate. And it turns out that the hospital and health system that has the fastest hiring speed hires the most. They beat the competition. They beat the health system with the highest salaries. They beat the health system with a huge, academic brand that's, nationally and globally known. They have just essentially said, when a nurse applies, and when we get a hold of a nurse, we are going to implement this no nurse left behind philosophy. And we are going to find some place for this nurse to go, somewhere in our giant health system, and interviews are going to be done in 3 days. Job offers are going to be made same day, and we're going to get this nurse through the door. And that creates an extremely positive impression of an employer from a nurse's perspective. Like, wow, if that's my hiring experience, maybe the whole health system is running this way, right? And it has really turned into a huge competitive advantage for those hospitals.
So, question over here. Have you got a microphone? Yeah. I'm so glad you have questions. Thank you for having questions. Maybe we should just all say them all at once and we'll, yeah. So, yeah.
Hi, thank you all. I'm Heather Lane. I'm from Athena Health. We're a major manufacturer of electronic health record systems. And I know that you called out EHRs as a real pain point. And believe me, internally, we are acutely aware of this. We're aware of documentation overhead for providers and clinicians. We're aware of the pain points, some of the pain points in our EHRs and so on. We're also aware of the potential that we can offer through, the large data that we do have. I'm interested from each of your perspectives what we in the EHR markets can be doing to help this problem.
We have a project going on. It's called Project Joy, and it's in nursing. It's to streamline documentation to bring the joy back to nursing. But, just having that ear and just being at the bedside with whether it's a physician or a nurse is really important. I think where we're going is the big data side of things, and how do we pull the data out to give us good information back, whether it's surveillance data, whatever. I think that's important, so that makes sure your data, and it's there, it's easy to retrieve. We have good algorithms. There's been good partnerships so that we can make something out of that data and put real high-performing teams on it to make change.
I think we've got a primary care provider back here.
I'm also primary care.
Well,
Now
then
I've got two.
share the question.
Go for it.
Yeah, all right. High five. Love it.
Love this talk. I always think of the 5 whys, and I feel like we've gotten down, but I feel like we're still not down to the 5th why here. Nursing profession is a wonderful profession. Being a primary care provider is a wonderful profession. I led 185 family medicine physicians in a big multi-specialty group. I'm seeing them retire younger and younger, decrease their hours. I feel like the 5th why is you got to the structural, it's also the economic misalignment. and it's making the job sustainable. So I worked on a support team where we had, we said, you know, the physicians, as you say, the administrative burdens, and I'm doing the RN's work because we can't afford an RN, or I'm doing the PharmD's work because we can't afford a PharmD. You know, so if you hire the whole team, I had one site where I got the burnout rate down to 0.
Oh,
And
bravo.
it
Bravo.
didn't quite stay there, but it went way down. And I had ways of looking at the data, and I said, you know, you're putting in the same hours. What's the difference? And one doctor told me, the joy of medicine is back.
Yeah.
I am doing what I was trained to do. I have support around the patient. My patients can get a response quickly, and I can do what I'm trained to do. And when they say, can you add a patient? Yeah, of course, because I have that team. Instead of staying there till 8 or 9 at night, or doing it at home where I'm continually doing all the administrative things. It's more of a statement, but just kind of also, where are we going with the alignment? I just joined Primary Care Collaborative, which is really trying to look at that alignment.
The alignment would
But
be
that's
another
the question.
panel.
Oh, okay, sorry.
But we hear you. But I do want to comment on your phrase about using joy. I know, Corey, several of us have worked with organizations where there's joy in medicine, there's joy in nursing, and what I think is beautiful is that we are using that word and recognizing that this moral distress really comes from a place of where it's eating at the soul of people who are trying to care for people. And when you don't have that joy, and that's what so many of the work that the foundation is doing, that Iman's team is doing, that Kathy's team is doing, a lot of this is structural, a lot of this is alignment of business and strategy, but at the core of it, it's people taking care of people. And that goes from not only the employer taking care of the people, but when you take care of the people who take care of the people, there's so much joy in all of that. So before we close, I think we've got time for one more question. Up here, Mackenzie? Yeah.
I'm also a primary care provider, but I'm traveling for pediatrics, and I've also been a nurse.
I just want to get a show of
yeah.
hands. How many practitioners do we have in the room? We love you. I just want to make sure you know how much we love you. Thank you for being here.
Yeah.
Yeah.
Thank you for having us, and thank you for having this talk. I think it's 100% pertinent and also something that's been talked about for a long, long time. The nursing staff and the workforce has been talked about since before I was in school for it. So I appreciate you guys. I think Dominique kind of touched on this a little bit, the why. I mean, obviously the joy of it, but I think there's a systems change we talk about throughout this whole conference that's not necessarily going to happen without policy and advocacy. And I'd actually like to hear from Corey about your thoughts on that, just because you have been doing that work, and then also how you're incorporating the frontline staff into that work specifically.
Yeah, so we'd love your help. I honestly, I mean, Shauna and I were talking about, she storms the Capitol in Austin on a regular basis, and they give her tons of reasons to do it daily.
Yes.
You know, nurses and physicians and other healthcare professionals are so well trusted by members of both parties that your ability to go with a consistent message to Capitol Hill, share your story, and share solutions, I think is actually one of the most powerful things. We need to get all kind of healthcare professionals elected into local and state government as well as federal government. I was recently doing a talk in Montana, and they were looking at some of this was in the last year, so it was the post-Roe world, and there was a bunch of doctors, and they were lamenting the fact that a bunch of policymakers had come up with laws that were just completely impractical, and that makes perfect sense given that there wasn't a clinician in the room. So I think you need to be absolutely active and part of it, and I would say alignment on your message and what solutions are. As you know, healthcare is like the most siloed industry, and so what I hear is often doctors want one thing, hospitals want another, nurses want another, but locking arms around what the solutions are to make the environment better, what those policy solutions are, pre-authorizations, all of those kind of things, I think that's the key. And I will tell you, when we got our federal law passed in 18 months, it usually takes about a decade to do that, but we did it because we brought your stories with us. And I think never lose sight of the power of your story. Brene Brown calls stories data with soul, right?
Yeah.
And those are what move policymakers. So Would love to talk to you after this, too.
Yeah.
And that is such a great plug for all of you to subscribe to the See You Now podcast so that you can listen to my voice regularly and hear all of their stories.
Now you have an image.
Now,
you
yeah,
have an
now you
image.
know what the voice really looks like. We've shared a lot of data and some really great stories. And what I want to leave you with is that we are immersed in talking and having conversations with people who are on all levels of healthcare. It's not just front lines, it's all levels. And they are carrying a lot of stress, a lot of distress, a lot of burden oftentimes. But the number one reason why they stay, actually not the patients, it's actually not all these other things, they stay for their colleagues. And that is this real power of bringing the joy back to the work that we do. So when we, like I said, we shared with you some very jolting statistics. We want to, because when you feel things, you will be motivated to act and motivated to take on these incredible, easy to implement solutions, actually. They're not that hard. It's more the mindset. And it's when we go and have these conversations and we share the stories and we have the evidence and the data to back it up. That's where the movement really happens. So I just wanted to leave you with that and thank this incredible group of folks.
Thank you all. Thank you all.
And I do want to say thank you all for being here, and also to J&J for hundreds of years of making sure that the nursing workforce is cared for.